Welcome back to the deep dive. Today feels different. Usually we sit here, coffee in hand, and casually unravel a topic just for the sake of, being smarter. But today I feel a little sick to my stomach.
Oh. Did you eat the cafeteria sushi again?
No, nothing like that. I'm role-playing. I'm putting myself in the shoes of our listener right now. I want you to imagine the scene. It's a humid morning in Ahmedabad. You're standing outside this heavy wooden door at Gujarat University.
I know this scene.
You're wearing a formal shirt that's already sticking to your back. Your palms are sweating. In your hand, you're clutching this frayed notebook full of scribbles from Morgan, Miller, and those high-yield notes from Kaushik Jathanath.
Ah, yes. The MD anesthesiology exam, the Viva Voce.
Exactly. And behind that door are 4 senior examiners who have, heard it all. They don't want textbook regurgitation. They want to know if I'm safe to be left alone in an OR.
Yep.
So here's the setup. You are not just my co-host today. You are the senior professor, the external examiner, the one with the glasses perched on the end of his nose who, smells fear.
I can do that. I can be the terrifying barrier between you and your degree.
And I'm the resident. I read the books. I swear I have. But my brain is just this jumbled mess of facts and graphs and conflicting percentages. I need you to help me organize this mountain of information into an answer that will actually get me passing marks.
Okay.
The topic on the table: regulation of body temperature, hypothermia, and hyperthermia.
It's a beast of a topic. It sounds simple. I mean, everyone knows what a fever is, right? But when you really dig into the physiology and the anesthetic implications, it's a minefield. And frankly, it's one of the most clinically relevant things we do every single day.
So let's simulate the exam. I walk in, I sit down, you look at me over your glasses and say, "Doctor, tell me about thermoregulation." Where do I even begin without just, rambling?
Okay, stop right there. The first thing you do is take a breath. You have to start with the why. Don't just jump into degrees Celsius or hypothalamic nuclei. You need to frame the biological stakes.
Oh, why? Okay.
You look the examiner in the eye and you say, "Sir, humans are homeotherms."
Homeotherms, right. Meaning we keep our temperature constant?
Yes, but contrast it. You say, unlike poikilotherms, like reptiles, whose body temperature fluctuates with the environment, we burn a tremendous amount of metabolic energy to lock our core temperature within a very tiny, specific range.
And then I explain why we do that.
Exactly. Why? Because we are essentially a walking, talking bag of very, very sensitive chemical reactions.
This is the enzymatic argument, right?
From the Miller, it's the core of the whole thing. Yeah. Miller and the Oxford Handbook make a huge point of this. Our enzymes, our coagulation cascades, our sodium-potassium pumps, our drug-metabolizing proteins, they are all exquisitely calibrated to work optimally at 37 degrees Celsius.
Oh.
If you drift away from that, even by a degree or two, the whole machinery starts to grind to a halt or speed up uncontrollably. Drug metabolism slows down, blood stops clotting properly, the heart gets irritable.
So my opening statement to the examiner should be something like, temperature isn't just a comfort issue. It's a fundamental requirement for our biochemical survival.
Precisely. And then you immediately hit them with the clinical relevance. You say, and that's why this is critical in anesthesia, because perioperative hypothermia is arguably the most common complication we see.
I like that. Most common. It shows I'm thinking about prevalence.
It's often ignored because, it doesn't bleed and it doesn't scream. But the outcomes, we're talking increased infection rates, myocardial ischemia, prolonged hospital stays, they're devastating.
So if I frame it that way, I'm showing the examiner I'm not just a bookworm, I'm a clinician thinking about patient safety.
That's how you pass. You show them you're safe.
Okay, I set the stage. I see the examiner nodding, maybe a little. Now he asks, fine, so what is normal body temperature? This seems like a trap. Is it just 37 degrees?
It is absolutely a trap if you just say 37. That's a first-year medical student answer. You need to show nuance.
Okay, so how do I answer that?
You have to immediately distinguish between the core and the periphery. This is the shell concept from Guyton.
Right. The core is the engine room, the brain, the heart, the liver, the kidneys.
Correct. The deep tissues, the thoracic and abdominal viscera. That is what we are defending at, say, 36.9 degrees Celsius plus or minus 0.4. That's the treasure. But the shell,
the skin, the subcutaneous fat, the arms and legs.
that's a buffer zone. It's insulation.
And the temperature there is different.
Oh, significantly. In a comfortable room, your skin temperature might be 33 or 34 degrees. There is a temperature gradient from the core out to the periphery, usually about 2 to 4 degrees Celsius.
Hold on. I want to stick a pin in that gradient concept. That feels really important. I have a feeling that's going to come up later when we talk about why patients drop their temp so fast right after induction?
It is the single most important concept in this entire discussion. If you don't understand the gradient, you cannot possibly understand redistribution hypothermia. And if you can't explain that, you're in trouble. So yes, we will come back to that. Big time.
Okay. And also, regarding normal temperature, it's not a flat line throughout the day, is it?
No, absolutely not. You have to mention the diurnal variation. It's a circadian rhythm. It follows a sine wave pattern.
The ICU books love this detail.
They do, and so do examiners. Your temperature is at its lowest, the nadir in the early morning, maybe around 6 a.m. It then peaks in the late afternoon.
So if I'm on a morning round and I'm measuring a patient at 6 a.m. and they're 36.2, that might just be their normal physiological rhythm.
Exactly. Context is everything. It's not just a number. It's a number in the context of time, location of measurement, and the patient's physiology.
Got it. Okay, let's talk about the heat balance equation, supply and demand. Let's start with heat production. Where is this heat actually coming from?
Well, the baseline heat, what Guyton calls the fire of life, comes from your basal metabolic rate, or BMR.
So just the act of being alive.
Just the act of existing. Pumping ions across membranes, building proteins, cellular respiration, all these processes are inefficient, and they generate heat as a byproduct. That's your pilot light. It's always on.
But the pilot light isn't enough if I'm standing in a freezing exam hall or a cold operating theater.
No, not at all. If you need to ramp up heat production, you have two main engines you can fire up.
Okay.
The first, and most important for adults, is muscle activity, specifically shivering.
I've read some crazy stats on this. How much heat can shivering actually generate? It feels like just little twitches.
It's a massive booster. Shivering is an involuntary, asynchronous, high-frequency muscle contraction. It's not about doing work. It's about being inefficient on purpose to generate heat.
And the numbers.
Morgan and Miller state it can increase heat production by 50 to 100% very easily. In extreme physiological models, some sources quote up to 200, even 500% above baseline. It is the body's emergency furnace.
That sounds great for heating up, but
I mean,
there's always a cost, right? Nothing in physiology is free.
there's a huge cost. The cost is oxygen. To fuel that shivering, your muscles are screaming for oxygen. This is a critical exam point. Shivering increases total body oxygen consumption by 200 to 500%.
Wow.
It's a massive cardiorespiratory disease.
Which brings us to the danger. If I'm a healthy 20-year-old, I can shiver off a cold night and be fine. But if I'm a 70-year-old with coronary artery disease in the recovery room,
Then your heart cannot supply that extra oxygen. Your coronary arteries are already narrowed. You start shivering, your myocardial oxygen demand skyrockets, but the supply can't keep up. And what does that cause?
myocardial ischemia, a heart attack.
Exactly. You can have a heart attack in the PCU just because you're cold. That's why we treat shivering so aggressively. It is not a benign sign of recovery.
Okay, so shivering is the main defense for adults. So if I have a neonate, a newborn baby on the operating table, and they get cold, I should expect to see them shivering vigorously, right?
Stop. If you say that in the exam, you fail.
Really? That clear cut.
Immediate fail. Think about it. Have you ever in your life seen a shivering baby?
Now that you mention it, no. They just get quiet and sort of mottled and blue.
Exactly. Neonates have tiny, underdeveloped muscles. They cannot shiver effectively. They would waste too much energy for too little heat. So they rely on a completely different and much more efficient engine called non-shivering thermogenesis, or NST.
This is the brown fat mechanism.
Yes, brown adipose tissue, or BAT. In neonates, it's located in specific places between the scapulae around the neck, surrounding the kidneys and adrenal glands.
Why is it brown?
It's brown because it is packed to the gills with mitochondria, and it has a very rich blood supply and sympathetic innervation.
Okay, so how does it work? Is just burning fat like normal fat?
No, it's a very specific and elegant biochemical hack. Normally, mitochondria burn fuel to create a proton gradient, which then drives the synthesis of ATP for the body's energy currency.
Right. Oxidative phosphorylation.
In brown fat, sympathetic stimulation releases norepineway. This activates a unique protein in the mitochondrial membrane called uncoupling protein 1, or UCP1. It used to be called thermogenin.
Uncoupling. So it uncouples the fuel burning from the ATP production.
It does exactly that. It pokes a hole in the dam. It creates a proton leak, allowing the protons to flow back across the membrane without generating ATP. All that potential energy is instead released directly as heat. It's a biological space heater. Incredibly efficient.
Okay, so that's for babies. Does this happen in adults at all? I think I read in Stolting or the newer Miller that adults have some brown fat.
It's a point of active research, and it's good extra marks point to mention.
Hmm.
The consensus in the newer Miller editions is that, yes, adults do have some functional brown fat, particularly around the neck and supraclavicular areas, and it can be recruited in response to chronic cold exposure.
But it's not our main engine.
Not at all. Compared to shivering, its contribution in an adult is negligible. So for the exam, you keep it distinct. Shivering is for adults. Non-shivering thermogenesis is the primary mechanism for infants.
Got it. Okay, what about hormones? Do they play a role in heat production?
Yes, but more on a chronic background level. The thyroid hormones, thyroxine in particular, set the overall metabolic rate of all cells. So a hyperthyroid patient runs hot, and a hypothyroid patient runs cold.
And catecholamines.
Epinephrine and norepinephrine can also ramp up cellular metabolism, but that's usually part of a broader stress response rather than a specific thermoregulatory one.
Okay, I think I have a good handle on heat production. Now let's flip the equation. Heat loss. We are constantly losing heat to the environment. I remember a mnemonic from Dr. Podcast scripts for this. Royal College exam room.
It's a classic because it ranks the mechanisms in order of magnitude in a typical operating room environment. This is absolutely essential for the physiology question. You need to know the physics, not just the names.
Let's break it down then. R for royal. Radiation.
Radiation is the heavyweight champion. In a standard OR, it accounts for 40 to 60% of all heat loss from the patient.
Explain the physics here for me, because when I think radiation, my mind goes to, Chernobyl or X-rays.
No, think infrared, like a thermal camera. All objects above absolute zero emit electromagnetic energy as infrared rays. Radiation is a transfer of this heat energy from a warm object, the patient, to a colder object in the room. The walls, the floor, the surgical light fixtures, without any physical contact.
So it's line of sight. Does the air temperature in between matter?
No. And that's the key concept. It's independent of air temperature. Your patient is 37 degrees. The operating theater wall is maybe 18 or 20 degrees. The heat literally jumps across the space from the patient's skin to the wall.
That's actually terrifying. It's a constant invisible heat bleed.
It is, which is why simply covering the patient's skin is so important, even with a thin sheet. It breaks that line of sight and dramatically reduces radiative loss.
Okay, C for college. Convection.
This is the wind chill factor. It typically accounts for about 30% of heat loss.
How does that work?
Air is a good insulator if it's still, but if it's moving, it becomes a problem. Cool air molecules flow over the patient's skin, they pick up heat through conduction, become warmer and less dense, and then they rise and are replaced by fresh, cool air. A continuous cycle.
This must be a huge issue in those fancy orthopedic theaters.
The laminar flow theaters, absolutely. Those rooms are designed to have 15 to 20 air changes per hour to maintain sterility. But for the patient, it's like lying naked in a constant, gentle wind tunnel. Convective loss can skyrocket in those environments.
Right. Okay, E for exam. Evaporation.
Evaporation counts for roughly 20% of heat loss. It's the energy loss when water changes from a liquid to a gas.
Where's this water coming from?
Two main sources. One is insensible loss from the skin and sweating. The other is from the respiratory tract. We humidify the dry medical gases we breathe in and exhale warm, moist air.
But surgically, this can change dramatically, can it?
Drastically. This is a huge factor. Imagine a major laparotomy. You open the abdomen. You have meters of bowel. A massive, moist, warm, vascularized surface area suddenly exposed to the dry OR air. The evaporative loss is immense. It's like sweating from the inside out. You can lose huge amounts of heat and fluid this way. Same for a major burn patient who has lost their skin barrier.
And finally, the last one. C for conduction.
Conduction is the transfer of heat through direct physical contact. Heat moving from the patient's body to the cold operating table or the ECG leads or the blood pressure cuff.
This sounds like it would be a small player.
Usually it is. Maybe 5% or less, because we use foam mattresses on the tables, which are good insulators.
But you mentioned fluids earlier.
That is the exception. That is also conduction. If you pour a liter of room temperature crystalloid, which is maybe 21 degrees, directly into a patient's vein, you are mixing that cold fluid directly with their core blood. That is a massive conductive heat loss. Same with unwarmed blood products from the fridge.
Okay, so we have the heater, which is metabolism, and the 4 ways the heater can lose its heat to the environment. Who is the conductor? Who's controlling the thermostat?
The hypothalamus. This is exam gold. You need to be able to draw the schematic of this control system. It's a classic negative feedback loop.
Guyton splits it into an anterior and a posterior section. I always get them mixed up under pressure.
Here's a simple way to remember it. The anterior hypothalamus is like the AC unit. It's the heat loss center. The posterior hypothalamus is the furnace. It's the heat gain center.
Okay, so interior equals anti-heat.
If that works for you, sure. The anterior hypothalamus, specifically the preoptic area, has heat-sensitive neurons. If the blood flowing through it is too hot, it triggers the cool-down mechanisms, vasodilation, to dump heat to the skin, and sweating for evaporative cooling.
And the posterior...
The posterior hypothalamus is more of an integration center. It receives signals from the anterior hypothalamus and from the peripheral cold receptors. If the body is determined to be cold, it orchestrates the heat-up response.
Which would be?
Vasoconstriction, to trap heat in the core. And if that's not enough, shivering.
So how does it know what the temperature is? Is it just sensing the blood temperature in the brain?
That's the primary input, yes. The central thermoreceptors in the hypothalamus are incredibly sensitive to the temperature of the blood bathing them, but it also gets reports from the field.
The peripheral receptors.
Right. There are thermoreceptors all over your skin, in your spinal cord, and in deep tissues. And interestingly, we have about 10 times more cold receptors than warm receptors. We're much more sensitive to cooling than warming.
The Oxford Handbook mentions something here for extra marks. A specific type of channel.
Ah, yes. The thermo-TRP channels. The transient receptor potential channels.
Sounds like something from Star Trek.
It's Nobel Prize-winning science. These are fascinating ion channels on the nerve endings that physically change their shape at certain temperatures, allowing ions to flow and generating a nerve signal.
For example?
For example, the TRPM8 channel is activated by cold temperatures and also by menthol. That's why mint feels cold on your tongue. And the TRPV1 channel is activated by heat and also by capsaicin, the chemical in chili peppers. That's why spicy food feels hot.
Dropping TRP channels into a Viva answer would probably get a nod of approval.
It shows you're reading beyond the basic texts. It shows you're interested in the mechanism.
Now, explain the set point concept. This seems crucial.
It is. Think of your home thermostat. You set it to 21 degrees. If the room temperature drops to 20.9, the heater kicks on. If it goes up to 21.1, the AC kicks on. That 21 degrees is the set point.
And the body has one too.
An incredibly precise one. In an awake, healthy human, the interthreshold range, that's the technical term for the null zone where the body does nothing, is only about 0.2 degrees Celsius.
That is unbelievably tight control.
It is. You're constantly making micro adjustments, vasodilating a little, vasoconstricting a little, to keep your core temperature locked in that narrow band.
We also have behavioral responses, right? Before all the autonomic stuff kicks in.
Absolutely. Yeah. And in fact, behavioral regulation is our most powerful and efficient effector. Feeling cold, you put on a sweater. Feeling hot, you move into the shade.
But the crucial point for us is...
Under anesthesia, that is the first thing to go. Your patient cannot ask for a blanket. They cannot tell you they're cold. Their most potent defense is completely abolished.
And this is where the wheels completely fall off when we start giving anesthetic drugs.
This is the pivot point of the entire exam answer. We've built the foundation of normal physiology. Now we move to part C, the effect of anesthesia on thermoregulation.
Okay, so I induce my patient. I give them propofol, fentanyl, rocuronium. I secure their airway. What happens to that finely tuned hypothalamic thermostat?
You smash it with a hammer.
Yeah.
Nearly all general anesthetic agents, volatiles, propofol, profoundly impair central thermoregulation. The primary effect is that they widen the interthreshold range.
Widen it by how much? You said it's normally 0.2 degrees.
They widen it by a factor of 10 or 20. Instead of 0.2 degrees, the null zone expands to about 4.0 degrees Celsius.
Wait, hang on. 4 degrees. So the patient's core temperature can drop from 37 all the way down to 33, and the brain just doesn't care.
Precisely. The hypothalamus basically says, hey, I'm fine. No vasoconstriction is triggered. No shivering is initiated. All the autonomic defenses are offline.
So the patient essentially becomes...
Ankylothermic. They become cold-blooded. They passively accept the temperature of the cold operating room.
That is a terrifying thought. Okay, I need to visualize this. The famous anesthesia temperature curve. If I'm in the written exam, I have to draw this graph, right?
It is mandatory. You draw it. You label the axis. X-axis is time in hours. Y-axis is core temperature. And you show the 3 distinct phases. You must be able to label them and explain the mechanism for each one.
Okay, let's walk through it. Phase 1, the first hour after induction. The line on the graph drops like a stone.
A steep, rapid drop. Usually 1.0 to 1.5 degrees Celsius in the first 45 to 60 minutes.
Why? This is the Viva trap, isn't it? The one you mentioned earlier.
It is the #1 trap. The examiner will lean forward and ask, Doctor, did the patient lose a lot of heat to the room in this first hour?
And my gut instinct is to say yes, because their temperature dropped, so they must have lost heat.
And you would be completely wrong. The answer is not heat loss. The answer is redistribution.
Walk me through this. Use an analogy to make it stick.
Okay, imagine your body is a house in winter. The core, your living room where the fireplace is nice and warm, say 22 degrees. The peripheral bedrooms, your arms and legs, are cold, maybe 16 degrees, because you've kept the doors closed to save on heating.
Okay, so that's normal physiology. The closed doors are the tonic vasoconstriction keeping the heat in the core. That's the gradient.
Exactly. Core is 37, periphery is 33. Now, you give a dose of propofol. Propofol is a potent vasodilator. It's like you just walked through the house and kicked open all the bedroom doors at once.
So the warm air from the living room rushes out into the cold bedrooms.
And the cold air from the bedrooms rushes into the living room. The air mixes. Now, has the total amount of heat inside the house changed yet?
No, the windows and the front door are still closed.
Right. There's been no net heat loss to the outside world yet. But what has happened to the temperature in the living room?
It dropped instantly because it mixed with all that cold air.
That is redistribution hypothermia. Phase 1 is not primarily heat loss to the environment. It is heat moving from the warm core compartment to the much larger, cooler peripheral compartment.
That is a fantastic analogy. Okay, phase 2. This is the next 2 to 3 hours. The line on the graph is still going down, but it's a slower, more linear slope.
Right. Now the windows are open. This is where actual heat loss to the environment becomes the dominant factor. The patient's metabolic rate is reduced by the anesthetic agents, so heat production is low. But heat loss via radiation and convection is in full swing.
So heat loss is now greater than heat production.
Correct. And the body isn't defending itself, so the temperature drifts steadily downwards in a straight line.
Then we get to phase 3, the plateau. The line flattens out.
Eventually, if the surgery is long enough, the core temperature might drop to, say, 34, 33 degrees. At that point, it finally hits the new, widened trigger point for vasoconstriction. The hypothalamus finally wakes up and says, okay, this is too cold even for me.
And it triggers the defenses.
It triggers thermoregulatory vasoconstriction. This traps what little heat is being produced in the core and dramatically reduces heat loss to the periphery. A new, albeit hypothermic, steady state is reached.
Okay, that's general anesthesia. What about regional anesthesia? Say I just do a spinal for a C-section. The patient is awake, they can talk to me, they can tell me they're cold, so it must be safer, right?
Wrong. It could be even more insidious. Morgan calls regional anesthesia the double whammy. It's profoundly disruptive.
Okay, what's whammy 1?
The same thing as GA, but localized. Sympathectomy. A spinal or epidural block knocks out the sympathetic nerves to the lower body.
And sympathetic tone is what keeps the vessels constricted.
So you get massive vasodilation in the legs. Warm blood from the core rushes down into the now vasodilated, cool legs. Boom, redistribution hypothermia. Just like in phase 1 of GA, the core temperature drops.
Okay, that makes sense. What's whammy 2?
Whammy 2 is a sensory illusion. You are lying to the brain. The hypothalamus relies on thermal input from the entire body, especially the legs, to build its picture of the body's temperature.
But with a spinal, those sensory nerves are blocked.
Correct. The brain gets no cold signals from the lower half of the body. In fact, it might even interpret the vasodilation itself as a signal of warmth.
So the patient's core is getting colder and colder due to redistribution, but the brain thinks everything is fine or even warm.
Exactly. The thermostat is completely fooled. The patient might have a core temp of 35 degrees, but they feel comfortable or even warm. They won't initiate any behavioral responses. It's a dissociated thermoregulation.
And shivering and regional.
It's common, but it's often confusing. The shivering typically occurs in the upper body, above the level of the block. The core is cold, triggering a response, but it can only manifest in the unblocked muscles. It's a very strange and uncomfortable sensation for the patient.
Okay, this is all setting a pretty grim picture. Let's move to Part D, hypothermia itself. Let's get the definitions clear for the exam.
Standard definition is a core temperature less than 36 degrees Celsius.
And the classifications.
It's pretty standard. Mild is 32 to 35 degrees. This is where you see maximal shivering. Moderate is 28 to 32 degrees. This is dangerous because shivering stops and consciousness becomes clouded. And severe is less than 28 degrees, where you have a high risk of coma and ventricular fibrillation.
And we should distinguish between accidental, like falling into a frozen lake, and perioperative.
Yes, because perioperative hypothermia happens in a controlled, clean environment. It's iatrogenic. It's our fault.
And it's preventable. Okay, the causes. We've covered anesthetic factors like vasodilation and hypothalamic depression. We've covered environmental factors like the cold OR. What about patient-related factors? Who is most at risk?
Extremes of age. Always. We mentioned neonates and infants. They have a huge surface area to volume ratio, so they lose heat incredibly fast. Plus, they can't shiver.
And the elderly.
The elderly often have a lower basal metabolic rate, less subcutaneous fat for insulation, and an impaired vasoconstrictive response. They're very vulnerable.
What else?
Think about the cachectic cancer patient. They have no fat, no insulation. The major burn patient, they've lost their skin, which is the primary barrier to evaporative loss. And patients with pre-existing conditions like hypothyroidism, their metabolic fire is already turned down low.
Right. Now, the physiological effects. This is the core so what section. Why do we care so much if the patient is a little chilly? Let's go system by system. Start with the cardiovascular system.
Initially, as you cool, you get a stress response. The body releases catecholamine, so you see tachycardia and hypertension. But as the hypothermia deepens, everything slows down.
How so?
The sinoatrial node's firing rate decreases, leading to bradycardia. Myocardial contractility is reduced, so cardiac output falls. Basically, the whole heart goes into a slow-motion state.
And the ECG changes. This is a classic exam question.
The classic finding is the Osborne J-wave. You have to mention this.
What is it exactly?
It's a little extra positive deflection, like a camel's hump, at the junction of the QRS complex and the ST segment. It's most prominent in the precordial leads. If you see that on a monitor, the patient is significantly hypothermic.
And the ultimate risk?
Below 28 degrees, the myocardium becomes incredibly irritable. The threshold for ventricular fibrillation plummets. And here's the kicker. VFib in a severely hypothermic heart is often resistant to defibrillation. You have to warm the patient up first. You're not dead until you're warm and dead.
Chilling. Okay, coagulation. This is the one that gets the surgeons yelling at us in the OR.
And for good reason. Even mild hypothermia causes a clinically significant coagulopathy. It's a two-pronged attack.
What are the two prongs?
First, it affects platelet function. At lower temperatures, platelets just don't get sticky. They don't aggregate properly to form a plug. Second, it impairs the enzymatic coagulation cascade. All those clotting factors are enzymes, and they work much more slowly in the cold.
Okay, but here is the trap I ran into as a junior resident. My patient was oozing from everywhere. I sent blood to the lab for a PT and an INR. The results came back completely normal. The surgeon looked at me like I was an idiot.
The lab trap. It's a classic. You have to understand how the lab works. They take your tube of cold blood from your 34-degree patient, they put it in their machine, and the first thing the machine does is
warm it up to 37 degrees to run the test.
Exactly. So the test results are an artificial reality. They tell you what the blood would do if the patient was warm. They do not tell you what the blood is doing in the patient right now.
So you cannot trust standard coagulation labs in a hypothermic patient.
You cannot. You have to treat the patient, not the number. You have to warm them. The coagulopathy of hypothermia is reversible with rewarming.
That is such a crucial clinical pearl.
Yeah.
Okay, drug metabolism.
Same principle. Most drug metabolism happens via enzymes in the liver and plasma. Those enzymes are temperature dependent. They slow down in the cold.
What are some key examples for the exam?
The non-depolarizing muscle relaxants are a great one. The duration of action of vicuronium or etricurium can be doubled by just a 2-degree drop in temperature. If you don't account for that, your patient will be paralyzed for hours in the recovery room.
And propofol.
Propofol clearance drops significantly. Plasma levels will rise. So if you're running a TIVA at standard rates on a cold patient, you are effectively overdosing them. Their emergence will be incredibly delayed.
What about MSC for volatile agents?
Good one. MSC decreases. The brain is less active, so you need less anesthetic. The rule of thumb is that MSC decreases by about 5 to 7% for every degree Celsius drop in core temperature.
Okay, last one for physiology. Respiratory system. The oxygen hemoglobin dissociation curve.
Hypothermia causes the curve to shift to the left.
And the mnemonic is left holds on.
Correct. Or left loves oxygen. The hemoglobin molecule's affinity for oxygen increases. It binds to it very tightly in the lungs, which seems good, but it then refuses to release it to the tissues.
So you can have a pulse oximeter reading of 100%, but your tissues are actually starving and hypoxic because the hemoglobin won't share the oxygen.
A dangerous state of affairs.
Yeah.
Disoxic hypoxia.
Okay, let's tie this all together into the big picture. Clinical consequences. What are the top 3 things I need to list on my exam paper?
Number 1. Surgical site infection, SSI. This is the big evidence-based one. There was a landmark study by Kurz and colleagues.
What did they find?
They found that even mild hypothermia, just 1.5 degrees, triples the rate of postoperative wound infections. Triples.
And the mechanism for that?
It's twofold. Thermoregulatory vasoconstriction reduces blood flow. and therefore oxygen delivery to the wound. Neutrophils, our bacteria-killing cells, need oxygen to function. No oxygen, no killing. Also, immune function itself is directly impaired by cold.
Okay, infection is number 1. What's number 2?
Increased blood loss and transfusion requirement. This is a direct result of the coagulopathy we just discussed. Patients bleed more, they need more transfusions, which has its own set of risks.
And number 3?
Morbid cardiac events. We talked about how shivering in recovery is a huge oxygen demand. In patients with heart disease, this can tip them over the edge into myocardial ischemia, arrhythmias, or a full-blown MI.
So we have to stop this. Let's talk prevention and management. This has to be an exam favorite.
It is, because it's practical and it's all about patient safety. The most effective strategy, the one you must write down first, is pre-warming.
Tell me more about that. Why does pre-warming work so well? Is it just about banking extra heat in the patient?
That's part of it, but it's more clever than that.
Yeah.
It directly counteracts the main problem. It fixes the gradient.
The core to peripheral gradient.
Right. Remember the house analogy. If you put a forced air warmer, like a bear hugger, on the patient for 30 to 60 minutes before you induce anesthesia, you're actively heating up the bedrooms. You warm the periphery. You decrease that core to peripheral temperature gradient.
So when I give the propofol and kick all the doors open,
There's less of a temperature difference between the rooms. The mixing effect is blunted. You can almost completely abolish that initial steep phase 1 drop. Pre-warming is the only strategy that effectively prevents redistribution hypothermia.
what about just piling on cotton blankets, passive warming?
Passive warming is, well, it's better than nothing, but not by much. Cotton blankets are insulators. They reduce heat loss by about 30%. But an anesthetized patient is producing very little heat to begin with.
So putting a blanket on a cold anesthetized patient is like putting a cozy sweater on a cold stone. It just keeps the stone cold.
That's a perfect analogy. You need to add heat from an external source.
Yeah.
You need active warming.
Which brings us to the forced air warming devices.
The Bair Hugger is the gold standard for cutaneous warming. It's a disposable blanket that blows warm air over the patient's skin. It directly combats heat loss from radiation and convection, which, remember, are the two biggest culprits.
And fluid warming.
Absolutely essential, especially for large volume resuscitation or big cases. The rule of thumb I use is 1 unit of refrigerated blood or 1 liter of room temperature crystalloid will drop the core temperature by about 0.25 degrees Celsius. That adds up incredibly fast in a trauma case.
And of course, monitoring. We need to know if our interventions are working. Where do we put the temperature probe?
This is a common point of confusion. The true gold standard, which we rarely use, is the pulmonary artery catheter because it measures the mixed venous blood temperature.
But clinically, in a routine case,
Under general anesthesia, the distal esophagus is best. The probe sits right behind the heart and aortic arch, so it's a great reflection of core temperature. The nasopharynx is also very good.
what about the bladder?
Bladder temperature via a Foley catheter is acceptable, but it can lag behind, especially if the urine output is low.
And the one place you should not use.
The axilla, the armpit. If you write that down as a core temperature site, you will fail. It measures skin and ambient temperature. It's completely unreliable.
Okay, I feel good about hypothermia. Let's pivot. We've been talking about cold for so long. Let's talk about heat. Part E, hyperthermia. First, the critical definition.
For an exam, you can say hyperthermia is a core temperature above 37.5 or 38 degrees Celsius, depending on the textbook. But the mechanism is what matters more than the number. You must be able to distinguish fever from hyperthermia.
What is the fundamental difference? They both mean the patient is hot.
Yes, but the why is completely different. Fever, or pyrexia, is a software problem. The hypothalamic thermostat set point is reset to a higher level.
How does that happen?
Pyrogens, like interleukin-1 released during an infection, travel to the hypothalamus and tell the brain. Our new target temperature is 39 degrees.
So the body actively wants to be hot.
Precisely. That's why you get chills and start shivering when you have a fever. Your current temperature of 37 degrees is now perceived by your brain as being too cold compared to the new higher set point. The body is working to warm itself up.
And hyperthermia.
That is a hardware failure. The set point is still normal at 37 degrees. The body wants to be cool, but it can't. Either the heat production mechanisms are out of control, like in malignant hyperthermia, or the heat loss mechanisms are overwhelmed or broken, like in heat stroke.
This distinction is everything when it comes to treatment, right?
100%. Antipyretics like paracetamol or NSAIDs work for fever because they act on the hypothalamus to lower the set point back to normal. But giving paracetamol to a patient with hyperthermia does absolutely nothing because the set point is already normal.
So for hyperthermia, and you have to physically cool the patient.
You have no other choice. You have to use external cooling measures.
Okay, so what are the common causes of hyperthermia in the perioperative period?
The most common is probably iatrogenic. We simply leave the Bair hugger on for too long or set it too high. It's easy to overshoot.
What else?
Infection leading to sepsis, of course. Endocrine emergencies like a thyroid storm or a pheochromocytoma crisis. And certain drug reactions like serotonin syndrome or neuroleptic malignant syndrome.
And the big scary one we always have to have in the back of our minds, malignant hyperthermia, MH. We're not doing a full deep dive on MH today, but we need to mention how it fits in.
MH is the classic example of hyperthermia from uncontrolled heat production. It's a pharmacogenetic disorder of skeletal muscle.
Triggered by?
The volatile anesthetic agents like sevoflurane and desflurane, and the depolarizing muscle relaxant succinylcholine.
And the defect is in the ryanodine receptor in the muscle. What happens?
In susceptible individuals, these triggers cause the ryanodine receptor to open and stay open, leading to a massive, uncontrolled release of calcium from the sarcoplasmic reticulum into the muscle cell.
And all that calcium causes?
Sustained muscle contraction and a hypermetabolic crisis. The muscle is burning through ATP at an incredible rate, which generates a phenomenal amount of heat and carbon dioxide.
So in a Viva, how do I tell it apart from just a patient spiking a fever from sepsis?
The key differentiator is the end-tidal CO2. MH is a hypermetabolic crisis first and foremost. The earliest and most reliable sign is a rapid, sustained, and otherwise unexplained rise in EtCO2. Muscle rigidity, especially the jaw, is another key sign.
And the temperature.
The temperature rise is actually a late sign in MH. In sepsis, you usually get the fever first. In MH, you get the hypercarbia and rigidity first, and the fever follows. That's a critical distinction.
Right. And management of hyperthermia in general. What are the principles?
First, immediate action. Remove the cause. If it's MH, stop the triggering agents and give dantrolene. If it's an overzealous Bair hugger, turn it off. If it's sepsis, start antibiotics.
And then cooling.
Active cooling. Get ice packs into the axillate, groin, and around the neck. Administer cold VV fluids. In extreme cases, you can do things like gastric or bladder lavage with ice saline.
Then supportive care.
100% oxygen to meet the massive metabolic demand. Treat the severe metabolic acidosis that will inevitably develop. It's an all-hands-on-deck emergency.
We are in the home stretch now. Part F, exam integration. This is where we bring it all together to secure the pass. Let's start with some quick-fire comparison tables.
Okay, you need to be able to rattle these off. Let's do hypothermia versus hyperthermia.
Okay, effect on MAC.
Hypothermia decreases MAC. Hyperthermia increases MAC.
Cardiovascular.
Hypothermia. Bradycardia, Osborne J-waves, risk of VF. Hyperthermia. Tachycardia, high output state, eventual failure.
Coagulation.
Hypothermia, platelet dysfunction, impaired enzymes, clinical bleeding. Hyperthermia can lead to DIC in severe cases like sepsis or heat stroke.
Okay, now fever versus hyperthermia, set point.
Fever, risk set point. Hyperthermia, normal set point.
Body's response.
Fever, body tries to warm itself, shivering. Hyperthermia, body tries to cool itself. Sweating, vasodilation.
Response to antipyretics like paracetamol.
Fever, effective. Hypothermia, ineffective.
Excellent. Now, what are some common exam questions and Viva traps I should anticipate? We mentioned the redistribution trap. What else?
They might ask you, doctor, your patient is shivering violently in the recovery room. What is your differential diagnosis?
And the answer isn't just they're cold.
No, that's too simple. A good candidate gives a differential. It could be thermoregulatory shivering due to hypothermia. It could be a response to pain. It could be non-thermoregulatory shakes related to volatile anesthetic washout. Or, more ominously, it could be rigors from a transfusion reaction or early sepsis.
So you need to show you can think beyond the obvious.
Yeah. Always. Another trap. Doctor, why not just warm the IG fluids and forget about the forced air warmer? It's less clutter. Because you're treating the wrong problem. Warmed all four fluids only treat conductive heat loss, which is a tiny fraction, maybe 5% of the total heat loss. The forced air warmer treats radiation and convection, which account for up to 90% of the loss. You have to treat the biggest source of the problem.
And finally, for the written paper, the diagrams and presentation, what am I drawing?
You need 3 key diagrams. 1, the heat loss pie chart, showing the relative contributions of radiation, 60%, convection, 30%, evaporation, and conduction.
2,
the hypothalamic control schematic, a simple flowchart. Inputs, central peripheral receptors, go to the hypothalamic center, which then sends signals to the outputs. Vasoconstriction shivering or vasodilation sweating.
and the most important one.
The anesthesia temperature curve. You must draw the graph showing the 3 phases: the steep phase 1 redistribution drop, the linear phase 2 loss, and the phase 3 plateau, and label them.
Okay, Professor. I'm standing at that wooden door I'm about to go in. Give me the final summary bullet points, the absolute take-home message for my brain.
All right, take a deep breath. Here is your cheat sheet. This is what you need to know.
I'm ready.
1. Humans are homeotherms, and this is vital for our enzymatic and coagulation functions. 2. The core to peripheral gradient is key. Anesthesia destroys it.
Okay.
3. Radiation is the #1 enemy in the OR, accounting for up to 60% of heat loss. 4. Redistribution is the #1 cause of the early rapid temperature drop. It's not heat loss.
Got it.
5. Anesthesia makes the patient hypokilotherm by widening the interthreshold range to a massive 4 degrees Celsius. 6. Hypothermia's main dangers are infection, bleeding, and cardiac ischemia.
Right.
7. Pre-warming is the only way to effectively prevent that initial redistribution drop. And 8. Trust the patient, not the lab, when it comes to coagulation tests in a cold patient.
Wow. Okay. That actually makes sense. I feel slightly less nauseous.
That's the goal.
Yeah.
Knowledge and structure are the best antiemetics for exam anxiety.
Thank you, Professor. This has been invaluable. And to our listener, if you're preparing, draw that graph right now. Grab a napkin, a piece of paper, anything. Draw the 3 phases of perioperative hypothermia.
Lock it into your muscle memory. Do it before you forget. Good luck.
Stay in the OT.